All right, let's talk about something that is a real head scratcher in medicine. A type of shock where the very treatments we rely on, the things that are supposed to save a life, can actually push a patient over the edge. We're going to dig into how that's even possible. So here's the big question, right? Why would doing the exact thing you're supposed to do for shock make your patient worse? I mean, it goes against everything we're taught. It's a clinician's nightmare, and it all points to this one very specific diagnosis that's so easy to miss. So check this out. Here's a real-world case. We've got a 69-year-old man who comes in with urosepsis. Things go south, and he has a cardiac arrest. The team gets him back, but his blood pressure is still in the tank, so they start him on norepinephrine. But here's the twist. The more they increase the pressors, the lower his blood pressure goes. It makes no sense. Then someone grabs an ultrasound, and there it is, the big clue. The heart isn't weak or failing, it's beating like crazy. It's hyperdynamic. What you're seeing here is a patient in a total state of paradox. Everything is the opposite of what you'd expect. So what in the world is going on? Well, the bad guy in this story, the hidden saboteur, is a condition called dynamic left ventricular outflow tract obstruction, or for short, LVOTO. Okay, so what is this hidden obstruction? Let's peel back the layers and see what's actually happening inside the heart. You know, the heart's whole job is to pump blood out to the body through an exit, an outflow tract. In LVOTO, something really weird happens. During the squeeze, part of the mitral valve, a leaflet that should be staying put, gets sucked into that exit path. This is called systolic anterior motion, or SAM. Just imagine a door that's supposed to open out suddenly swinging in and blocking the hallway. It creates this functional traffic jam, right, at the heart's main exit, and this is where everything gets turned upside down. In your typical cardiogenic shock, the heart's pump is weak, right? So we give drugs called inotropes to make it squeeze harder. But with LVOTO, the heart is already squeezing way too hard inside a small, empty chamber. So giving inotropes here is literally like pouring gasoline on a fire. It just makes that obstruction, that door swinging the wrong way, even worse. And when we make that mistake, when we give those inotropes, we kick off this awful self-perpetuating cycle, a truly vicious spiral. Here's how that spiral takes hold. First, you start with low fluid volume. Our guy had sepsis, for example. That makes the left ventricle chamber physically smaller. So, to keep up, the heart starts beating more forcefully. And if we add an inotropes, we're just fueling that fire. This super strong squeeze in a tiny space is what sucks that mitral valve leaflet into the exit path, creating the obstruction. Now, with the exit blocked, even less blood gets out, the shock gets worse, and what does that make us want to do? Add more inotropes, and around we go, spiraling down. So the million-dollar question is, how do we stop this? Well, you have to spot it first. And this is where that bedside ultrasound becomes your absolute best friend. Let's look at the clues. Okay, your spidey senses should be tingling if you've got a patient in shock who just isn't responding to pressors, or even worse, they're deteriorating after you give them inotropes. Then you put the ultrasound on their chest and you see a heart that's just squeezing like crazy in a tiny little chamber, and there's no other good reason for the shock, like a big clot in the lungs. You have to start thinking LVOTO. And the smoking gun, the thing that confirms it, it's when you can actually see that mitral valve leaflet getting pulled forward, creating the blockage, seeing SAM in action. All right, so we've found it. We've identified the enemy. Now for the most important part. How do we break the cycle? And this is where the treatment gets really, really weird and completely counterintuitive. I mean, just look at this playbook. It is literally the opposite of what we normally do. You have to stop the very drugs you thought were helping, those inotropes. You avoid things that would make the heart's chamber even smaller. Instead, you do what feels wrong, but is absolutely right for this patient. You give them fluids to fill up the heart, you give beta blockers like esmolol to actually calm the heart down, and you use specific pressors like phenylephrine that raise blood pressure without making the heart beat harder. Yeah, you heard that right. The whole goal is to make the heart less vigorous and more full. It sounds crazy, but it's the only thing that works. By filling the tank with fluids and easing off the gas with beta blockers, you make the ventricle bigger. This allows that rogue valve leaflet to fall back where it belongs, opening up the exit and breaking the cycle. So let's boil all of this down. If you're going to remember just one thing from all of this, let it be this next point. Here it is. In a patient with shock, if your ultrasound shows a hyperdynamic, furiously beating left ventricle, and you don't see any other cause like right heart strain, you have to think about LVOTO. It's totally treatable, it's reversible, but you can't treat what you don't diagnose. Missing this can be fatal, but catching it can turn a patient around in minutes. So I'll leave you with this thought. The next time you're standing at the bedside and the pressors are failing and you're scratching your head wondering what's going on, will you remember to reach for that probe and look for the hidden obstruction? Thanks for joining us.